Alright folks, what we're going to go ahead and do is continue the shoulder and work our way down the upper extremity. So what I like to do, again, we talked about grabbing the muscle belly, and to get the anterior portion of the trapezius musculature, we have more of a horizontal plane line going here, and what I'd like to go ahead and do is give her some impulses. This is about medium to light force as far as where we have the dial is concerned. It's about halfway screwed in to 3/4 of the way. And what we try to do is, again, for patient comfort, we have our hand attached to the probes as we're giving the impulses and starting to work the musculature. Another important thing to do is the anterior portion of the shoulder when we start getting conditions like adhesive capsulitis or frozen shoulder syndrome. A lot of times we'll get a lot of fibrotic tissue built up in this area that will contribute to the restricted range of motion. Sometimes the patient will only be able to raise their arm about this high. So when that's the case, in a neutral position, what we can do is go ahead and grab the muscle tissue here on the deltoid and start working. And I usually try to go inferior superior in my line of drive here and start working the muscle tissue. You can also go across the front of the body here and start working the top of the clavicle. Clavicular adjustments are very easy with this device. It is a wonderful device for the classic painful clavicular adjustment. When somebody puts their clavicle out of place, they're usually in a lot of pain, and having a fast speed, low impact device is imperative to be able to correct these conditions. Mattering on where the placement is, a lot of times you can look at the manubrium and you'll see if it's offset in a superior or an inferior position, you'll actually be able to see where you need to move. If it's in a superior position, you'll come up underneath the clavicle. Now make sure when you're applying the adjustment, especially on females, that you're not coming in straight on like this. But what you do is you turn the stylus to the side and you're coming in an upward position like this. Always having your second hand stabilizing in the area for patient comfort and security. So when you want to go ahead and go up into an I to S line of drive, you can give some impulses here, and whether it's more towards the midline or more towards the AC joint, you'll be able to have that opportunity. As far as going into the superior to inferior planes, again, this is a very important plane to apply, and you don't want to be coming straight onto the body. You want to be coming down the surface or down the plane of the body. Very important for not only patient comfort, but also patient security. Always very important. So we have the triceps and then we have the biceps. A lot of times you'll get inosopathy occurring, which is pain in or swelling at the origin of the tendon or insertion point of the tendon. What you want to focus on in this aspect is you start giving impulses to the tendon, and you can loosen things up if there's a restriction. One of the most common conditions we get in our office are things like lateral epicondylitis or medial epicondylitis, nursemaid's elbow or tennis elbow. And in this respect, what we want to focus on is working the muscle belly, not so much the joint itself. Joint mobilization can occur. Go ahead and turn a little bit, please. You can go ahead and work on that, but you want to work away from the joint. You don't want to be adjusting into the joint. When we're working with extremities, you're always trying to get traction out the joint, deliver the adjustment going away from the joint line. You don't want to increase pressure to the joint, you want to decrease pressure to the joint. So you can always contact on the distal portion of the humerus here. You have 2 or 3 impulses here. And also what you can do is contact onto either the ulna or the radius, and you can give more of a proximal to distal adjustment, creating space in the joint and opening it up a little bit. When we start dealing with the lateral or medial epicondylitis, we're talking about more of a tendonitis issue. And this is a very effective adjustment to the actual muscle itself to create change. Adjustment's all about creating change in the body. Adjusting a joint back into place is a chiropractic adjustment. Adjusting a muscle is much more of a therapeutic value, but nonetheless, we're able to stimulate mechanoreceptors and allow the body to relax itself, thereby by causing decrease of pain. So as far as going into the brachioradialis musculature here, you start working the plane line of the brachioradialis, and it's very easy with multiple impacts to work the muscle belly, and more importantly, even the borders of the muscle as well. So a lot of times the fibrotic muscle tissue or the fibrosis will try to combine the muscle compartments. So what we're going to try to do is break that apart a bit and loosen it up in that respect. Moving on to the wrist, our classic carpal tunnel syndrome. Now, mattering on the severity and the pain levels of the patient, you need to adapt your force settings again. What I like to do is open up the canal, and I almost always use the dual probe when I'm trying to open it up. Remember, we're dealing with a tunnel here. We want to open up that tunnel a bit. So just going ahead and going right onto the metacarpals here, we're able to open them up and create more room as far as for the medial nerve to come through. The median nerve, when it comes through the wrist, can be given more space to travel with simply opening up those bones, as well as working on the tissue. I like to open up the thumb and work the thenar and hypothenar. And as far as sometimes people come in with trigger thumb or trigger finger, what we can do is we can come right down